It's taken a little bit because you're orthopedic surgeon, I'm plastic surgeon. Trying to get us to schedule. So we're filming in Florida at a meeting because that is the best. Well, today I have on the show Dr. Joshua Schacter. And so Josh and I met at a meeting last year in September, the Mindshare Summit, and we wanted to have him on. He's an orthopedic surgeon in Wichita Falls, but he has a very unique approach to his practice. He uses and integrates functional medicine practices, lifestyle, nutrition as components to get a better approach to taking care of patients. Not too dissimilar from what we do with our patients who are undergoing explant surgeries. So welcome to the show, Josh.
Thank you, my brother, for having me on.
It's taken a little bit because you're an orthopedic surgeon, I'm a plastic surgeon. Try to get us to schedule. So we're filming in Florida at a meeting because that is the best time we could find to get this done.
Ships passing in the night.
This is perfect. It's early in the morning.
Right.
It's a little hazy outside, but that's all fine. So when we met and first discussed this, I have a great interest in all things stem cell related, orthobiologic related. I was an associate professor of orthopedic surgery before I finished my academic career, before they, shuttled me off. So I did plastics and ortho, and I helped. I worked with orthopedic surgeons closely throughout the time I was in training, of course, and then in practice when I started, I worked with musculoskeletal oncologists. So I did all of predominantly their, reconstruction, and their skeletal reconstruction things are just unbelievable. The things they do for their patients.
It's amazing. It's there's some really cool stuff in orthopedics and plastics.
Yeah,
Very stimulating.
the things that I saw frightening. So as we move, through practices and transition to different, forms of I guess our practices.
Right.
So I predominantly do explants, not implants. I use a big functional medicine approach and detox approach with all of my patients.
Mm-hmm.
And so for the audience listening, how do you do that with your patients with, say, joint pain or problems that are musculoskeletal problems that we probably, as we all age, have?
Oh yeah.
And
Yeah.
I'm not immune to this. Every day, got some ache and pain when I get out of bed.
Right. I mean, it's so common, especially in America, especially with our lifestyles, our busy lifestyles. It's like we don't slow down until something stops us, right? Like we
That's very American.
all of a sudden we just fall off a cliff with our joint pain. Joint pain is so multifactorial. And orthopedics, one of the things that I've noticed through my career, and I've been doing this for 20 years, I've done, thousands of surgeries, but we really focus just on the structure, right? We're so focused on the structure that might be causing the pain that we really lose sight of of what the bigger picture is, which is what are the contributing factors, right? What are
Is this where you're going to tell me like spine surgery doesn't work?
I've had spine surgery. It does work.
Spine surgery is the scariest of all the structural surgeries.
I totally agree.
You're talking about, but not saying out. Spine surgery is wow. That's amazingly complicated from a structural standpoint.
Right. You know what? So if you have a nerve that's being pushed on by a structure, it makes sense that if you move that structure off the nerve, it's going to feel better, right? So that's the basis of spine surgery. I'm not a spine surgeon, so. But to me, looking at, particularly with large joint, you look at knee, hip, shoulder are my sort of specialties, and I've done adult reconstructive for years. We really are focused in on, well, that joint's arthritic, let's replace that joint. And so through my career, I sort of saw this, we're just focused on that joint. Are we focused on the general patient health? Do we want to reduce complications by helping patients with nutrition? I had patients that would come to us, and in a traditional orthopedic practice, you're seeing 50 patients a day. My PA would see 30. We'd see 80 patients together. Right. And so the line is, well, we need to do a joint replacement. let's go ahead and lose some weight, be healthy. Hard stop. That's all of the information that we could give. And so as we go through this sort of spectrum, as you work through that, you work with those patients, what I found through my career is that we're really, really focused, particularly in orthopedics, particularly in a practice where you might be an employed surgeon, you really start to focus more on getting a patient into an operation than getting that patient healthy and getting to the root cause of what might be there's more factors to that pain, right?
Do you feel like now more so than ever with a peptide, I'm sure we'll get censored for saying peptide, but with a peptide that now everybody understands what peptides are with semaglutide, which is Ozempic, and I'll just use that as an example of the the mentality of what pill shot drug can I take to lose weight?
Right.
And those all work.
They do. They work great.
And do you see, I've thought about this. So my philosophically, you have to follow, unfortunately, the money. So if those drug companies knew that they would alter the use of diabetes medications, they would decrease the amount of fast food being eaten, they would lose so much weight that they probably avoid joint replacements. Would they have done what they did? Because they're so altruistic in nature.
I don't feel like pharmaceutical companies are altruistic in nature. I, I think that's an interesting point. So one of the coolest things about our approach at the Pinnacle Method is that our goal is to prevent people from needing these major orthopedic surgeries at all, right? Like, so what if you could come and what if you could have some lifestyle management, apply functional medicine principles so that we can reduce inflammation, get the gut healthy, right? Optimize our nutrition, and then treat the joint locally with some modalities that we can really start to prevent major orthopedic surgery or put it off for years and years. But drug companies, it's not in the best interest of pharmaceutical companies to necessarily prevent surgery and hospitalization, right?
No.
We don't feel like drug companies have our best interest at heart, for sure. And we see that, doctors see it, patients see it. So the question is, would a drug company have put out this drug if they thought they could reduce surgery and improve health? And I really, personally, I don't believe that the goal of any pharmaceutical company is to improve population health.
No.
I feel like the purpose of these drug companies—
They got to make money.
Yeah, they make money. The shareholder is the purpose, right? So even though semaglutide is extremely effective at losing weight, and we're finding all these amazing things, right? It reduces Alzheimer's, it reduces joint pain. That's not just because it reduces overall weight. It reduces inflammatory changes due to high glucose, right? And insulin.
Well, if you don't and are not interested in eating fast food or binging on things, it's amazing what will happen to your body.
Yeah. So if we get this toxic shit, if you will, out of population. But so there's so many benefits to these drugs that were unforeseen by drug companies. I think that, they're just sort of rolling with it. But at the end of the day, they're going to try, and they're coming up with more and more options and ways to have people use medications.
I'm so cynical because I thought for sure, because I'm sure in your career as you started to see younger and younger patients need joints because they were so overweight and they had worn out a joint.
It's an epidemic.
That you were like, I thought for sure before the release of those peptides, the GL1P agonists, that you're going to be taking care of some 20 somethings with worn out joints.
Youngest person I've ever done is 27.
Which is so for everybody listening, that is absolutely ridiculous.
It's bananas. Now, in these cases, in very young joint replacement, there are usually underlying problems, pathologies, right? Where you have a hip malformation that can cause us to need a hip replacement early. One of the things, the most concerning trend that I see in orthopedics, other than the fact that we're doing about over 30% of joint replacements done in the United States, and this is a study that was done in 2018, so it's probably more now, right? Quite a bit more, are done what we would call prematurely. So we're doing joint replacements in younger patients who are not as healthy because the American lifestyle has impacted all of our health, right? Right? Who are eating inflammatory foods, who are taking drugs that are not metabolically optimal,
Hmm.
right? Who are living a lifestyle that's not metabolically optimal, and they're having joint replacements at a much younger age. So
Right.
then the average age has shifted in the last 15 years from in the 60s to in the low 50s and even
Yeah.
into the 40s. And so what's the consequence of that? Not only do we have an increased problem with those patients needing joint replacement revisions, which are a much more complicated procedure, which have a much poorer outcome, but they also have the metabolic consequences of having major surgeries,
Because
of the
go back to
hearts.
what you said. So, like for everybody listening, the first time to operate on someone is the best time. Every time
Absolutely.
thereafter is always more complex for a host of reasons. And typically, it would start with each time you operate, you reduce blood flow to an area. So, its ability to heal is always compromised each and every
Yeah, we
time
damage the small
afterward.
vessels, right? So
Yeah.
you get scar tissue. That scar tissue isn't just painful to you, isn't just, stiff, but it also is less healthy, right? It doesn't heal as well. It doesn't move as well.
Right.
It doesn't metabolize as well. So it's a major impact. And so when we have major and orthopedic surgeries, whether we're doing them minimally invasive, when we have all these techniques, robots, robotic surgeries, computer assisted surgeries, those can help with your outcome, but they're not helping with the local soft tissues.
Yeah, it's comical because for 19 years all I did was oncologic reconstruction. So
Mhm.
we were joking a little bit earlier is the people I worked with who did musculoskeletal oncology, which is basically for sarcoma care, tumors of bone, muscle, of course, fat, just an amazing array of things that you would see. The most aggressive reconstructive surgery from a skeletal standpoint for the orthopedic surgeons, and then some of the strangest things I ever got
Yeah, flap
asked,
reconstructions and
yeah, asked to reconstruct from a soft tissue perspective. But the time the if there was a recurrence and revision of any of those, just like yeah, there's a recurrence or revision of anything I do, there's always more of a, increase in the complication rate. No matter who's doing it, makes no difference, no matter who's doing it,
yeah,
because for anybody, listening, like if he's doing an implant revision or if I'm doing an explant surgery, if we're taking all the material out, that's probably the best case scenario. But for skeletal reconstruction, he can't do that. You have
yeah.
to have that material in place, or your knee doesn't work, or your hip doesn't work, or your shoulder doesn't work. For explants, when I take everything out, I'm removing all the scar tissue, which relieves what can be a pretty significant biofilm burden depending on the patient. And there are tons of reports in the literature over time that when I was writing my paper about bacterial contamination on explant specimens, there's a species of bacteria called Ketibacterium acnes, which used to be called proprion bacteria, that was shown in shoulder implants
Yes, it's a
to
major
be a
problem.
huge problem because
Major problem.
that bacteria is in a high concentration on the skin of the shoulder, the chest, the neck, and the face. So
Yeah,
when
and the
people
axilla, right? In the armpit.
so when people tell me or criticize anything about, the papers are like we are like making things up, I'm like, well, this has been in the scientific literature in the orthopedic space for an incredibly long time
Yeah, it's one of the worst pathogens that we can have in a shoulder replacement, and it's also one of the most common
because of where
because of
where it is.
where it is, the location,
And I
location,
try to
location.
explain this, and it's frustrating. And this bacteria readily produces biofilm, which makes it more complicated for your body's immune system to clear.
And the challenge with orthopedics when we do major revision surgeries is we're taking an implant out that, that and the most common reason for revision is infection, right?
Right.
So you take an implant out with an organism that already had a biofilm, and then there's a lot of techniques, right? We could do multiple stage revisions and put
Right.
antibiotics, spacers, and these things, but then we go and put it back in, and then the most common complication of that is infection. So,
I want to go back for a second because there was a term that I know you'll enjoy. It was always called aseptic loosening.
Yes.
I love that. That is code for biofilm.
That's well, the argument is, and you see it in your college, right? I read your paper. I love it. They, in the surgical
Polyware.
arts,
Polyware.
we look at stuff and we go, oh, that doesn't exist. It's not an infection. Now we're allergic to a metal. Now we have a metal allergy, right? It's an aseptic loosening.
Right.
I think that bacterial burden, even if it's not grossly infected, plays a role in a lot of these revisions. And I think the take home is not necessarily that revision surgeries are complicated or that they're dangerous or they're causing a lot of societal burden and cost to the system, but that we're having to do them because we're doing so many surgeries so early now, right? We're doing all these interventions on people that don't necessarily right now need it.
What's the life cycle of the joint?
So, and this is really interesting because we have a lot of technology now, right? We got computers and robots and special stuff and programs and protocols and joint centers of excellence. And our longevity in joint replacements is not much more than it was in the 80s. So it's 10 to 15 years. If you get 25 out of a really good joint replacement, you're going to be super lucky.
Yeah.
But they don't last forever. And if you're getting a joint replacement in your late 40s, then there's a good chance that you're going to need a revision and that revision is going to have a suboptimal outcome.
So I'm going to raise my hand here because I know if I went to a regular orthopedic surgeon, if I got a bunch of opinions, they'd want to replace my knees.
Opinions are like assholes, right?
Everybody's got one. Well, because I've had 5 knee surgeries. I've had each one microfractured, which
yeah, absolutely,
very well. And I started having more and more pain. And I was pushing like maybe 185 for those of you listening, pounds, and for my folks in Europe, 80 kilos plus. And so I was like, well, I got a couple choices. I can go see Dr. Josh, or I can just get my lazy self up and start working out and go in the morning. And man, if you lose 5 pounds, I can see the change in someone's face and neck. And I don't know, your parameter for like in your mind, you probably have a tell about whether it's 10 or 15 or whatever, but it does affect how your joints feel to take the stress of the weight off of those. So I'm much better in terms of how I feel when I stand all day and operate, and I do a lot of recovery things now, as we've talked about. But for those people who don't, so your goal is to get them tuned up so they don't need potentially joint surgery. So you're going to do, I'm all right. I'm your patient. I'm 55. My knees are achy all the time, and I'm, let's just say, I don't know that I should not be eating gluten. What do you do for me?
I think that so historically in orthopedics, we say, well, everybody's too heavy. We need to lose some weight, right?
Right.
So weight loss is going to be critically important. We know that for every 10 pounds that we lose in an average American who would be, 180 to 220 pounds, every 10 pounds that we lose when we're in that, over 30, 35 BMI, that your knee scores will improve by several points, right?
What's the knee score?
So there's a HUES and a KUES. There's functional scores that we have that we use in orthopedics. And there's scores that we use both before and after joint replacement. So it combines pain, function, that sort of thing.
Okay.
Your ability to do
so you're scoring how
yeah, so you're gonna improve just simply by weight loss, and it can be as little as 5% of your your body weight. But that's that's what most orthopedic surgeons will look at. So, okay, well, I need you to lose weight and I need you to generally be okay and healthy. But other than that, I need to get you into the operating room because I got to do a bunch of surgeries because insurance pays me less and less for everything that I do, that sort of shit. So, but when we look at you as a whole organism, when we take a functional medicine approach, when we use our Pinnacle method, the first thing that we want to really do is assess your metabolic state.
Okay.
Right. So we want to get down into why, you have knee pain. There's a mechanical problem, right? You have arthritis. But why would some people with moderate arthritis have very severe pain? And why would people with more end-stage arthritis in some cases not have much pain at all? What's the underlying problem there, right? Like, is it really that the joint's not functioning well, or is it that the metabolism is contributing so much to your joint pain?
Because you said structurally, like unless it's compressing a nerve, uh, there shouldn't necessarily be a ton of pain.
We don't have to have a whole lot of pain in an arthritic joint. The cartilage surfaces don't have any nerves at all, right? It's the bony surfaces, it's the lining of the joint that really has the nerves. So if those bony surfaces are inflamed and irritated and overcompressed, then that can cause pain. If the lining of the joint is really irritated and inflamed, then that can cause pain. And we in orthopedics, in pure traditional orthopedics, we look at it as, oh, it's a structural problem, right? It's this problem that we have in the joint itself, and they don't really take into account the fact that that joint is connected. The knee bone is not just connected to the leg bone, it's also connected to the heart and the liver and the gut. And if we just, in simple terms, if we look at your overall systemic inflammation, then we can make major changes in how your joint feels.
So how are you going about measuring inflammation? Like obviously you have historical things they will tell you. Maybe they don't methylate well, so they have prolonged problems with recovery after if they could
Right?
exercise.
Yeah.
Are you using specific biomarkers that you prefer?
We do well. We use inflammatory markers. Use CRP, Cedrate. There's all those the basic inflammatory markers, but we also do biomarkers. We do about 100 in our method. We do about 165 different biomarkers. So we
Okay.
look at methylation. We look at overall metabolic health and wellness, and then we also look at the gut. So the gut's so critical in what you do, right? It's a huge
So
part
how
of
do
your.
you assess it?
So we do GI mapping,
Okay.
and we do food sensitivity testing.
Okay.
And then we're constantly sort of expanding as functional medicine and as the approach becomes more sophisticated to the gut, we're expanding our method as well. So we're learning, how
Right.
important the gut is in how your joints feel. I mean, how many we have as a part of our approach before we do an intervention, whether it's a surgery or an orthobiologic intervention. And full disclosure, I don't hate surgery. I think it's amazing. I just hate the way we do it in this country, right? Like getting people into high volume practices where all our goal is just to do a joint replacement. You had a steroid injection that didn't give you the
Right.
relief that you wanted. We did 2 physical therapy visits, and then we said, "Oh, you failed physical therapy because that's what the insurance company requires," and then we go to surgery, right? So that's not the way we want to do it at all. But
Yeah.
when we
There are
do,
other
there
alternatives.
are so many alternatives. But when we just really look at your overall inflammatory rate, it makes a huge difference. One of the biggest movers in our practice is an anti-inflammatory diet. We have a health coach. We have health coaches that when we start when we start the journey with a patient, we put them on an anti-inflammatory diet, and oftentimes in 2 weeks, the patient's joint pain will be reduced, even in severe, like end-stage arthritis with deformities. Joint pain will be reduced by 20%.
Now you're in Wichita Falls. I
Yep.
imagine you have some people that like their high fructose corn syrup. So is that
Do.
is that part of your you
Yeah.
cut that out of the diet?
Yeah. So we remove, we've got to get that gone. We have, and not just high fructose corn syrup. It's an evil one, but processed foods in general are so inflammatory.
Right.
If you don't believe in leaky gut, that's okay, but leaky gut believes in you. So that's the problem, right? So that
Right.
your gut is about 70% of your immune system. And if we don't take that into account with joint care, we're missing the boat. We're missing a lot of things.
Yeah, I mean, I always joked about the orthopedic surgeons that I trained with and worked with because there were some of I knew they were incredibly bright. They were just a little bit lazy at times. I mean, they're just super bright people. And
Right.
what Dr. Schachter's talking about, obviously, if you think of how your gut works with your brain and then integrates with everything else in your body, it's incredibly important that everything you put in your body and on your skin and what you breathe and what you drink goes into making, how you feel, experience things better
Yes.
or worse in instances. If I do all those changes over a 3 to 6 month period, but I still have like lingering pain, tell us kind of what you would do, as a more of an intervention
Yeah.
with one of your best kind of orthobiologic preps.
So in our practice, most people come and they want to have, they probably need to have something done. The problem with a joint is it's sort of this environmental, it's connected to the whole body, but it is an environment that's sort of hard to change sometimes because
It's a closed
it's a
space.
closed space.
Yeah.
And when you have a compromised joint, say you have some arthritis, right? The arthritis itself can cause you minimal discomfort, but when the joint becomes inflamed and irritated, the lining of that joint becomes really inflamed and irritated,
Right.
and it can be very difficult to lessen that inflammation.
Right. So the synovium.
The synovium, the lining of the joint, the synovial lining. Well, what we find is that we can do lifestyle management, we can do gut, we can do functional medicine, we can add supplementation, we can do things like GLP-1s can make a huge difference. Losartan, which is a like a blood pressure medication, can actually help with joint pain. There's a lot of strategies that we can use, but if we don't do something directly to the joint, it takes a really long time for wellness interventions to get people where they want to be as far as their activity levels. And our patients that come to see us, they don't want surgery. They want to avoid that, but they also are very active, right? So they want to play golf. They want to pick their grandkids up. They want to play soccer. They want to ref those football games, and they want to have something done. So our goals really are to get those patients turned around pretty quickly, and a direct joint intervention earlier than 3 to 6 months often makes a lot of sense. So what we do is we clean up the metabolism. We do the anti-inflammatory diet. We start with supplementation. We have health coaching. We do mobility work, but we also will do an intervention. So we'll start with an orthobiologics program, and that typically will start with PRP. Platelet-rich plasma can make a huge difference in and how much inflammation we have in the joint. The platelet is it's pretty magical little fragment of a cell. Platelets are not just, and when we do a PRP, we take your blood, we spin it in a centrifuge to concentrate those platelets very highly. Typically what we want to get is about 10 times or 10x what's in your normal volume of blood.
Right.
And we inject that into the joint. But we don't just do the joint itself. And this is, I think, one of the pitfalls is that, a lot of orthopedic surgeons in particular that are trying to do regen, they just put the stuff in the joint. We need to put it around the joint. So we do what's called a segmental approach. We treat the tissues around the joint and in the joint with PRP.
Okay.
And we can actually use different formulations. So we can use PRP, that's more specific to treat soft tissues, and we can use PRP that's better for inside the joint.
Okay.
There's different ways we can do that. The cool thing about PRP is not only is it a massive anti-inflammatory, it also works pretty fast. So if you do a steroid injection, which is terrible shit, don't do steroid injections into joints. We can talk about that. But when we do PRP, not only does it act inside the joint, but it also has a bit of a systemic effect.
Okay.
So we get an anti-inflammatory effect system-wide and very powerful locally. But another cool thing about PRP is it sort of preps the joint for stem cell. And stem cells, or mesenchymal stem cells is my preference to use as an orthopedic surgeon. That's rocket fuel for your joint. So oftentimes what we'll do is we'll do PRP first, and then we'll come back in and we'll do what's called bone marrow aspirate concentrate, where we take actually some of your bone marrow, which the best place to get that is the pelvis. We do a minor procedure that's relatively painless, and we take and concentrate those cells and then treat the joint with that. Typically, it's within a couple of weeks to about a month after the first injection, and that joint has been prepped and sort of.
So that's your sequence.
Yeah, that's our
Okay.
sequence. And then we'll even come in and lay on another PRP injection if we need to. And then we have some treatments that actually augment and increase the amount of materials that those cells release when we put them in. And for us, that's laser therapies.
Okay.
It's an MLS M6 laser that we use. But shockwave therapies are effective here as well. There's several different therapies. And what we find is that when we're doing the metabolic approach with orthobiologics together, it makes a huge difference in how patients do.
Can you, because I get asked about the shockwave approach for different therapeutics, and because that's not ever really been part of, what we would typically do. Can you explain like that how that would work in your practice? Why is that a good therapeutic option?
Shockwave itself?
Yeah.
Shockwave is it's a technology where basically you take high frequency sound and you inject it into the tissues so that it at a microscopic level is sort of shaking those tissues, and it causes them, it stimulates them. It can break up scar tissue. It can, and by stimulating the small vessels and the microscopic portions of those tissues and collagen, it can sort of break up and help collagen sort of reform into a more organized fashion.
But it's more frequency.
Yeah, it's frequency
Okay, so it's
based.
not like a Theragun.
No, a Theragun would be where we're actually
So it's
doing a
not hitting.
mechanical.
Yeah,
Yeah,
okay.
Theragun's hitting you. This is high frequency sound,
Okay.
and I think it's a fascinating technology. It's something that
So it's it's
really helps.
application of frequency therapy of sound frequency therapy. Okay.
Yes. Yeah.
Um, as I have gotten questions in the comments about that with the other shows that I really didn't have. Um, that's not my background,
Right.
honestly. So they do this, and whether you layer on other approaches or aspirate, and then you're looking for the Hughes score improvement. So
Hmm.
obviously you have a baseline, make their modifications in lifestyle, diet, exercise, prioritizing sleep for everybody listening.
Very much, and mindfulness. Don't forget mindfulness. The mind is so powerful, especially when we have pain.
Yeah, I was gonna say like at your place, so when we have because I do obviously a lot of explant surgery, we're immediately trying to get people in a parasympathetic state or a recovery state, if we want to just basically say that as quickly as possible. So we have all sorts of modalities that because we as surgeons spike cortisol with surgery, we have people who are in high states of activation. And so when they come in, we use hyperbaric in our office, and we have these lymphatic massage devices from New Zealand that actually warm the trunk area and really help get people into a more parasympathetic state. But obviously, sleep is incredibly important. And then I try to get people to perform what's called resonance breathing or like belly breathing. So you're calming yourself and increasing your heart rate variability just to promote recovery.
Right. Right.
So
Breath work, and so my wife and I, over the last probably 10 years, with our own health journeys, have found our way to sort of meditation and Eastern Tantra and breath work and these things. And, we can make it as simple and scientific and American as vagal breathing, right? Or box breathing. But those breathing techniques can make a huge difference for pain response, as you know.
yeah, what I try to get people to do is not focus so much on the 19,000 types of breathing, but
Right.
like just breathe in through your nose to count to four and out through your mouth or count to six so that
Mhm.
you're expanding your diaphragm so you bring your belly out, not suck it in.
Yeah. Prolonged
You
exhale, sort of
want
stuff.
and that will just, for lack of a better, not more detailed description, help you in terms of recovery.
It's all about, and when we do these, I think when we can approach joint care using all of these tools, what we find is that very few people actually need that major surgery right then. There's always going to be a group of people that or patients that come in who are going to need that joint replacement. And there's nothing wrong with surgical intervention when it's appropriate. But when we're doing almost 40% of our joint replacements in this country are being done prematurely for moderate arthritis or these types of problems that are, you can make an intervention and prevent those types of people from having to have that surgery for years. And the literature, a lot of, especially with bone marrow aspirate, some of these studies are preventing people from requiring joint replacement for 6 to 10 years with a
Yeah.
single injection of bone marrow aspirate. So now, if we can optimize you, if we can get you to think more critically about your health and make some health decisions, using anti-aging principles and the idea of longevity and functional medicine principles where we're getting to the root cause of your pain, then you might never need that joint replacement.
That's my goal. So let's do this. So currently you have to drive, fly, use your transportation to see Dr. Schacter in Wichita Falls. So I want him to tell you exactly where to contact him and how to follow him.
Yeah. So you can follow us on Instagram, Pinnacle Integrative Orthopedics. Pinnacle Integrative Orthopedics and Sports Medicine is our full practice name. Our website, www.pinnacleorthowf.com. You give us a call, 940-285-5007. I'm on TikTok, Dr. Joshua Schacter. For now. That's right. Well, we don't know for how long. We're on Blue Sky. We're on Facebook. Yeah, come see us. Currently, we have people that travel as far as California and the East Coast to see us. Wichita Falls is an interesting place to travel to. You can fly into Dallas. You can fly into Oklahoma City. We're about 2 hours away from each. Get a good audio book. I've got some recommendations.
That's right. I'm listening to the Gene right now. It's driving me crazy. It's reminding me of medical school and my biology degree. All right. Well, I appreciate you coming on. I look forward to, watching your practice grow and learning more about how you can help people avoid joint replacement.
Thank you, brother.
All right.
Appreciate you.